Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today I have with me one of the leading authorities in allogeneic stem cell transplantation from MD Anderson Cancer Center, Professor of Medicine, Dr. Muzaffar Qazilbash, and he is going to talk to us today about the role of allogeneic transplantation in acute myeloid leukemia. Thank you very much for joining us, Muzaffar.
Oh, thank you very much, Ravi, for this opportunity. And thank you for the kind introduction. It's always a pleasure to be with you. And of course, looking forward to this presentation.
So, what I think we'll start off with, Muzaffar, is obviously AML is a very challenging disease, a very complex disease. And I know I don't want to scare anybody with this algorithm that I put up on the slide. It just is to show people that there are a lot of decision points that we have, and how do we integrate where transplant falls into the frontline paradigm. So, how do you think through when you see a frontline patient? Whether this patient is going to need a transplant and how do you get him there?
Sure. No, it's an excellent point. And as you know, as someone who has been in this field of stem cell transplant, and whenever a patient is referred to me, and it's generally by one of my hem-onc or my leukemia colleagues, and a newly diagnosed AML walks into my clinic. So, of course, for me, the couple of very important questions. First, is this patient eligible for intense therapy, which includes stem cell transplantation? Or is this person not eligible for intense therapy? And you have nicely summarized that in your slide, like the first decision point, that there are patients who are older, or patients who are frail, or patients who have other medical problems, and those patients are not even considered for intensive therapy. So that's your red box below. So for us, for the purposes of this conversation, it's the patients who are eligible for intensive therapy. And these are the patients who are also eligible for stem cell transplant. And as you highlighted, that there are a lot of things that have evolved or have appeared in the treatment of acute myeloid leukemia. But again, when I see this patient who is younger, who is in relatively good health, who's eligible for intense therapy and potentially allogeneic transplant, my discussion is, well, you're going to receive induction treatment. This is the first combination of some chemotherapy to achieve some kind of disease control. We call it remission, as you know. So, and once they achieve remission, then of course, is not every AML patient who is potentially eligible for transplant needs a stem cell transplant up front. So those are the important decision point. Is this person fit enough to undergo intense therapy? If they do, is this patient eligible for stem cell transplant, or is this patient a good candidate for a stem cell transplant? So that's my first inclination. That's the first question that I ask myself. Happy to elaborate on it if you want.
Sure. So as far as as I said, the algorithm is fairly complex, and you beautifully put it that there are patients who are fit for intensive therapy, and they're the ones who can be even considered candidates for transplant. But you also said that not every one of those patients does need a transplant at the beginning. So just a little bit of explanation on who that is fit for transplant really needs a transplant at the beginning broadly.
Sure. So for that, of course, there are a number of guidelines, and I think one of the very useful ones is the European Leukemia Network. And before that, others have tried to. So when I see a newly diagnosed patient who I think is a fit patient for intensive therapy, in a very simplified way, we try to divide them, as we all do, into, is this patient or does this patient have a favorable risk acute leukemia? Would that be an intermediate risk, or would that be an unfavorable or adverse risk acute leukemia? So in general, those who are considered favorable risk acute leukemia, and like in your second set of boxes, the transparent boxes, you've put the core binding factor AML, like in version 16 and translocation 821. They are generally considered a favorable risk acute leukemia. So this person or this patient, or this group of patients who are favorable risk, and they are roughly about 1/3 to 40% of all newly diagnosed acute leukemia patients. If they respond to their treatment, they achieve a remission, these patients may do very well just with non-transplant chemotherapy. So that leaves us with the two other groups, intermediate risk or high risk. And there are some specific features in those high-risk patients based on chromosomal abnormalities or mutations, and then the intermediate risk who generally do not fit into either the favorable risk or high risk. So historically, and this has basically been supported by clinical trials as well as large registry data, that patients who are considered intermediate or high-risk disease and who have AML are potentially, if they are fit, they are eligible and are considered good candidates for allogeneic transplant. So in other words, those who are fit, I would say about 60% of those, or depending on how you describe it, about 2/3 of those would be considered candidates for transplant. The other 30 to 40% who have favorable risk may do very well, although they are potential candidates, but they may do very well even without an allogeneic transplant upfront.
And once these patients that are candidates and do need a transplant get their treatment, are you looking for some level of disease control before considering them for transplant?
Yes, so as we all who are in this field have seen that in general, the outcomes are better when patients have better disease control. So we try to achieve complete remission, where based on, of course, the bone marrow biopsy or blood tests, we do not see any evidence of leukemia. And about 70 to 80% of patients who receive induction treatment are able to achieve a complete remission. The only issue is that even if they achieve a complete remission and if we stop treatment at that point, there is a very, very high risk of relapse. So we try to achieve a complete remission in these patients before we take them to transplant, because the outcomes are better. Lower the disease burden at transplant, in general, better the outcome.
And we talked about transplant being part of the initial treatment paradigm for the groups that you thought were high risk and would otherwise not have good outcomes. Are there some that you do a transplant when their disease relapses?
Yes, so as we discussed, that even after induction treatment, some patients do not achieve a remission. Then there are patients who achieve a remission, like a good risk patient that we talked about, those 30 to 40%, and they have achieved a remission, but unfortunately not all of them are cured. If we take all acute leukemia patients and we treat them with chemotherapy, we discussed that 70 to 80% may achieve a complete remission, but only 1/3 of those are cured. So most patients need transplant either upfront or if they relapse. So again, there are patients where the disease does come back. And when the disease comes back, we go back to the same thing. Is this patient fit enough to withstand intense therapy? And is this patient a good candidate for allogeneic transplant? So yes, we do transplant for relapse patients also. And if I look at our patient population, it's roughly 50-50, because half of our patients who are getting transplant actually have disease that has relapsed after their initial treatment.
So do you tend to sometimes do a transplant as part of initial therapy, disease relapse, and then consider another transplant when it comes back?
So it is not, so we have done that also, but you again have to be very selective and careful, because If the disease comes back within 3 to 6 months of transplant, then subjecting a patient to a second transplant may not be the best option because the complication rate is much higher, treatment-related mortality is higher, and relapse rates are extremely high. But yes, if I have a young, fit patient, I've done a transplant, they had a 2-3 years of remission, and unfortunately the disease comes back, but the patient is still a good candidate for allogeneic transplant, we have a good donor, I would consider a second allogeneic transplant. Again, regardless of their fitness, the results of the second transplants are not as good as with the first transplant, but in appropriate patients, we do consider and we do offer a second transplant.
So obviously, hematopoietic stem cell transplant or bone marrow transplant and or stem cell transplant is something that words get used interchangeably. They all represent broadly the same procedure. But as far as the transplant goes for patients with AML, is it an autologous transplant? Is it an allogeneic transplant? And can you explain the difference between the two?
Sure. So for an autologous transplant, as we have now known for decades, so in autologous transplant, we collect the stem cells, the cells that make the blood and immune system, which normally reside in the bone marrow. So for autologous transplant, we collect cells from the patients themselves. So there we treat the patient, as we discussed, with an intense regimen. And if the patient achieves a complete remission, that's when we harvest their own stem cells, either from the bone marrow, or we can even bring them out into the bloodstream by using drugs called growth factors. And then when these cells are out in the bloodstream, using a line or a catheter and a machine called pheresis machine, we can collect these cells. So that's one approach. Allogeneic, as obvious from the name, comes from a donor. And then these cells, these donors could be, and we can talk about the donors, but in terms of stem cell source, we can get these cells directly from the bone marrow, where we take the donor to the operating room, and under general anesthesia, we can take out their bone marrow from their hip bones. We can do the same thing that I mentioned for autologous. We can give the donor growth factors, which brings out the stem cells into the bloodstream, and we can collect them by connecting their veins through a catheter to a pheresis machine. And then the third source of stem cell is cord blood. So, of course, this was the blood from newborn babies that used to be discarded. And then hematologists and scientists learned that it's a great source of stem cells. So then cord blood banks started, and people store these bloods, and this is a valuable source of stem cells. So some patients where we cannot find a bone marrow or a blood source, we can use cord blood. It's used mostly for children because the total number of cells are small, but it's another valuable source. So these are the allogeneic donors and autologous donors. But of course, they have their own pros and cons depending on the disease we are treating.
So in acute myeloid leukemia, what is the most common type of transplant and the source of cells used?
Sure. So for, in general, because the benefit of an allogeneic transplant comes not just from the chemotherapy, high-dose chemotherapy that we give to our patients to eradicate any remaining disease. So autologous transplant totally relies on that chemotherapy, that we collect cells from the patients, then we give them very high doses of chemotherapy, and then we give them back their stem cells. So the potential risks there are that we may have some residual leukemia cells, some remaining leukemia cells which are not detectable because their number is so small. And there is no what we call graft versus leukemia effect because these are patients' own cells. But when we use the donor, an allogeneic, here the benefit comes not just from the high-dose chemotherapy that we give to wipe out the disease marrow, but we also use the immune system of the donor, which sees patients' leukemia cells as something foreign and attack them. So this graft versus leukemia effect is very, very important and critical for achieving long-term disease control. So over the years, most transplanters have favored allogeneic transplant for acute leukemia patients because of graft versus leukemia effect. Of course, it's a more complex approach, as we will discuss.
So then you were starting to allude to the different donor types. Obviously, we talked about the sources, but we can get the cells from a number of different individual types, related, unrelated. So can you just broadly tell us about how you think through which donor source is optimal for a given patient?
Sure. So, and again, I mean, when a new patient comes to my clinic, after we have talked about the treatment, and once we come to transplant, and we've talked about what are the sources of stem cells, and then, of course, a very, very critical question, which has a very, very significant impact on the outcome, that who's going to be the donor, who that donor is. Once we have established that, well, you need the transplant, and the best transplant for AML would be a donor or allogeneic transplant. So a donor could be a related donor or an unrelated donor, as you have nicely highlighted. Now, that related donor could be a complete match. And most of the time, when we look for related donor, we are looking at siblings because, of course, all of us, we inherit one set of genes from each parent. So if a patient has siblings, there is a 25% chance that one of them would be a full match. And if someone has a fully matched sibling, that could be a potential donor. So that is our historically our preferred donor. But over the last decade and a half, we have learned that even a mismatched donor, which could be a sibling, which could be a parent for younger patients, or a child for older patients, can also be used by using certain approaches. What we have seen, and most of us, including your institution, has shown that even a mismatched donor transplant can be almost as safe as a matched donor transplant. So for related donors, we either go for a fully matched donor, which in most situations is a biological sibling, a brother or a sister, or it could be a haploidentical or a mismatched donor or a half-matched donor, which could be a sibling or a child or a parent. And then, of course, in the 80s and 90s, with better tissue typing, we learned that, well, there are donors, unrelated donors, who may also be used as a potential source for allogenic transplant. So as you said, that there is now a registry of more than 35 million volunteer donors who have willingly volunteered to donate stem cells if needed. So we can use a fully matched unrelated donor, or even one or two mismatches with some manipulation can also be used. So a number of options, and with all these options, more and more patients can potentially benefit from an allogenic transplant.
So how do you think through, which is, if you had a choice of doing all of them, how do you think through, in your mind, which is the best donor to go for?
Sure. So we all, of course, through our practice patterns, through the data, have worked out algorithms. So if I see a patient, if I have a fully matched sibling donor, and that donor is healthy and willing, I would go for that. My next approach would be matched unrelated donor, a fully matched unrelated donor. The potential advantage of having a fully matched sibling donor is the accessibility and rapid availability. Results for matched unrelated donors are now comparable to fully matched related donors also, but it takes time because you have to reach out to the international registry, and then the donor has to be identified. Donor has to do confirmatory testing. We as transplanters cannot directly contact those donors. So that has to be done through National Marrow Donor Program. So those things can take a little time. So if someone needs transplant right away, this process can slow things down. So that's why my algorithm is I would go for a matched related donor, then matched unrelated donor, and then my third option would be haploidentical donor. My fourth option would be mismatched unrelated donor. Now, there are situations where if I need the cells right away, now with greater safety of haploidentical, I would go with haploidentical. If a matched unrelated donor I'm having difficulty finding, or a donor is not available, because again, these are volunteers, they may have family issues, they may have travel or something else, health-related things going on. So match-related, matched unrelated, haploidentical, mismatch unrelated.
Thank you for that. So then, when a patient is getting ready for transplant, you found the donor, and now the patient is at the point of transplant. How do you proceed? What do you do in terms of getting the patient ready?
Sure. So, of course, once I have identified a patient and a donor, and now there is time to proceed, there are some other important things which I discuss with my patients. So, as you know, this is a complex process when patients are coming for an allogenic transplant. Because of anticipated side effects and all, they have to be physically present in the proximity of the transplant center. Even after the discharge from the hospital for roughly 3 months. So a magic number we talk about is 100 days after transplant. So we inform patients that they have to be prepared for that. So for that, they need some kind of local housing. Then these patients also need a caregiver, because especially they may be getting medications that would impair their ability to drive, or sometimes they may just not be feeling well, someone who could bring them to the hospital. So those are some of the important things. And then once they come, patient is admitted, the first 3 to 4 weeks would be in the hospital. This is when they get chemotherapy, or certain centers also use radiation therapy or a chemo plus radiation therapy. This is called the conditioning regimen or preparative regimen, which we admit the patients to the hospital and give them. Some of them can even be done as outpatient, but generally, let's say most patients need admission. So they get this chemo or radiation therapy to wipe out their own bone marrow and also to suppress the immune system so it can accept the donor cells.
And so obviously patients get a transplant, they get the infusion of the donor cells. So what are you worried about? What are you looking for in the days, weeks, and months to come?
Sure. And so that's a perfect segue. So I said that we tell patients that you have to be here for about 100 days or so. So the first 3 to 4 weeks when they are in the hospital, our biggest concern is the chemotherapy that we gave patients and the side effects related to that. So the first 10 days or 10 to 14 days, the effects of chemotherapy, including nausea, vomiting, diarrhea, sometimes mouth soreness and risk of infection, low blood counts. Those are the issues that we are focusing on. And then, of course, their blood counts recover because the donor cells go in the bone marrow, make new cells, and patients get discharged roughly 3 to 4 weeks after transplant. But the reason we wanted them here for the first 100 days is because these patients, although they may have normal white blood cells count, but they are also at risk of infection because they are immunocompromised and they are on anti-rejection medications or immunosuppressive medications. Also, as we said, that there is graft versus leukemia effect where donor immune cells can go after any remaining leukemia cell. But it's a double-edged sword. The same cells that can go after leukemia can see patients' own body as foreign, and they can attack the gut, the liver, skin, and that condition, as you highlighted here, is graft versus host disease. And there are types of graft versus host disease. If it in old days, we used to say that if it happens within the first 100 days, it is acute graft versus host disease. And then if it happens later, it would be chronic graft versus host disease. But it's not just the timing, it's also how these things present or manifest themselves. But definitely we are concerned about graft versus host disease in the first 100 days. We are concerned about infection. So we do some surveillance tests to make sure that there is no viral reactivation, there is no evidence of fungal infection, and we have a very low threshold to treat these things as soon as they appear. And of course, when we do the transplant, we obviously want the cure. So we are also monitoring for a response and any signs of disease relapse, which we hope obviously not going to happen, but we still do bone marrow biopsies and blood tests to make sure that the patient's disease is in control or is in remission.
So how often do you do these biopsies?
So there are, the general trend is that the first one we do roughly 30 days or 4 weeks after the transplant. So once the counts have recovered, patient is discharged, we would do a bone marrow biopsy that will confirm that, yes, patient is in remission. We now have very sophisticated tests which can not only tell us that when we look under the microscope, there are no leukemia cells. These techniques like flow cytometry or PCR can pick up 1 in 100,000 to 1 in a million cells if they are there. So those tests can tell us that even with that level of sensitivity, we are not seeing any leukemia. So we do those roughly 30 days, and then roughly before the patient is going home, so 3 months or 100 days. And after that, I think it varies, it depends. If I have a patient whose blood counts are completely normal, previous 2 bone marrows showed no evidence of leukemia, then I probably won't be repeating bone marrows every 3 months or so. I may do it 1 year follow-up again to confirm, or as needed. Like if I see that blood counts have dropped and I'm seeing any abnormal cells, that would prompt me to. But otherwise, after these 2 bone marrows, outside of clinical trial, I don't keep repeating bone marrow biopsies.
And can you tell with these bone marrow whether the donor cells are there, or how much of it is donor and how much, if any, is left from the original patient?
Absolutely. So there are now those tests, and we don't even have to do a bone marrow biopsy. So yes, we can send the bone marrow cells, which can tell us exactly what percentage of cells are of donor origin. And the goal is that 100% cells should be from the donor. But those tests can be performed on simple peripheral blood tests, or we can just take a small tube from the blood, send it to the lab, and they not only tell us that what percentage of cells are of donor origin, they can also look at different type of cells, that myeloid cell, which make certain type of white cells, to lymphoid cells, which make the cells of immune system, also white cell. So not only it tells us that 100% cells are of donor origin, but all different types of white cells are of donor origin. And it's very reassuring. And of course, it translates into good outcomes when you see that all the cells that you infuse are doing their job, and all you are seeing in patients' blood and bone marrow are of donor origin.
So I think that we do take a number of measures to mitigate some of the complications that we talked about, and I think we do have a separate video on our portal. And so I would probably, for those interested, for sake of brevity, ask them to visit the video, which gives a little more information on the prophylactic strategies for GVHD and infection. But I would like to now shift to the question that all patients ask. What is my prognosis? What is the success rate of allogeneic transplantation?
Sure. So, in general, the reason we do these procedures and these complex procedures is because the results are good. Of course, and it's a curative treatment. So in general, when we approach patients with this is not with the intention that we're going to control your disease or we're going to basically keep this remission going for so many months. It's the most important word is that we want to cure the patient. Of course, we don't always succeed, but as we went along, when patients come and they are in newly diagnosed, good candidates, they achieve a complete remission, and you treat them with allogeneic transplant with a good match donor, the success rate, which means a potential cure rate, could be as high as 60-70% or more. Of course, these numbers can go down if someone has other medical issues which increase the risk of treatment-related complications, or if their disease did not respond very well, although we can still cure, but the cure rate goes down. If the disease is resistant, there is remaining leukemia cells in the bone marrow. Same thing for relapse patients, that those who achieved a remission then come back for further treatment and transplant. Even in those patients, we can cure depending on the extent of the disease and aggressiveness of the disease, as high as 50% of patients. But again, that number can go down depending on their response to prior treatment, aggressiveness of the disease, and other complications that may happen after transplant, including graft versus host disease or infections.
So I guess our technology to transplant has certainly got better with time. Are we doing better today than we were, say, 10, 15 years ago?
So absolutely, and as you and I who've been in this field and been in this field for a while, the progress is incremental. It's evolutionary. It happens slowly, but as we have seen, like when I was a fellow, we would say that the treatment-related mortality rate would be 30 to 40% in those who are coming for allogeneic transplant. Patients who are 50 years old would be considered the upper age limit. Today, we are transplanting patients who are in their 70s. We can use lower intensity regimens. Our graft versus host disease prevention has improved. We have better drugs to prevent and treat infections. So because of that, although we are treating older patients, sicker patients, patients who have more advanced disease, but our treatment-related complications rate or death rate is down to 10 to 15% from 30 to 40% years ago. And that keeping in mind that we are treating older patients and patients who have other medical problems also. So yes, we still have some ways to go, but in terms of safety, we have made a lot of progress. We are constantly striving to improve the disease control. We've made some progress, but we still have room to do better.
But, patients often ask, is cancer curable? And obviously, cancer is not one disease, and there's so many diseases. It is but blood cancers, I tell patients, most of them, we have a chance at cure, whether it is drugs or whether it is with a transplant. And transplant certainly remains a very critical part, I think, of the curative approach for a lot of patients with acute myeloid leukemia. Is that fair to say?
Absolutely. I completely agree with what you just said.
Well, Muzaffar, I really appreciate you giving us the time to go through this. It is something that I hope will be of use to the patient community and the audience. You've done a fantastic job of distilling this in very simple terms, a very complex area. And obviously, people spend their career trying to figure out how to transplant, and it is very difficult to do justice to this in 20 minutes to half an hour. But I applaud you for your guidance here.
Oh, my pleasure. Thank you very much for doing this.
Thank you.